Hello, everyone. Welcome to another episode of Pod Bites, where we break down complex medical topics into bite-sized, high-yield episodes, perfect for your commute, coffee break, or whenever curiosity calls. I'm your host, Rawad Turko, and today I'm joined by Dr. Mohammed AlHajji. Dr. AlHajji is a consultant pulmonologist from KFSH and RC, and we are grateful that he gave up some of his time to teach us about asthma, chronic obstructive pulmonary diseases, and restrictive lung diseases. Thank you, Dr. AlHajji, for joining us.
Thank you very much. Good afternoon, everyone. And I'm very thankful for you for the kind invitation. It's an honor to be with you and to hear that I'm the first physician to do such an exercise. Thank you.
Thank you so much. Okay, let's jump right into the basics. What exactly is asthma, and how would you define any specific case as an asthma case?
Right. The definition of asthma has been changed fairly recently. The main reference body that most chest physicians or pulmonologists follow for asthma guidelines in general and for all asthma definitions is the GINA. Of course, there is a local version of the GINA, which is the SINA, the Saudi Initiative for Asthma Management or for asthma guidelines. The GINA defines asthma as a chronic inflammatory heterogeneous inflammation of the airways that is characterized by a reversible airway constriction. Clinically, asthma presents with symptoms like chest tightness, cough, and wheezing, and these symptoms tend to vary in intensity and in frequency in the same patients from time to time within the same period or between periods.
Okay. Now, thank you so much for this. You mentioned some of the things like chest tightness, but I want to know more specifically. I'm sure that there must be some sort of trigger for an asthma attack. Can you talk to us a little bit about that?
Of course, asthma in general is, for the vast majority of asthmatic patients, is an allergic disease. So hence there are triggers. These triggers are actually very diverse and they vary between patients. So each individual or each asthmatic patient has different triggers that can initiate the clinical presentation or the symptoms of the disease. These triggers can also vary in the same patients from time to time. The triggers are very diverse, very wide, can be environmental, exposure to dust, fumes, strong smells. These triggers also can be sometimes antigens from pathogens, so certain viruses or bacteria can trigger the disease. There are some specific triggers also that can be household, like the household mites, the dust, mold, damp atmospheres. Other triggers could be a little bit not usual or rare, like specific medications. Stress or exercise can also trigger asthma in certain patients.
Yeah. I feel like a lot of us in the university, we have a lot of trouble with the immune mechanism.
Yeah.
The trigger part is something very classic when you see in a presentation of a child who, for example, at a certain period of the year starts to have these asthmatic attacks. But the immune part is what we struggle with, the Th2 and
Yeah. It is rather complicated, and of course you can write a textbook about the pathophysiology of asthma. What should medical students understand or comprehend, at least the general pathophysiology of asthma? Asthma in general is, from the pathophysiology type, is divided into the type 2 or non-type 2 or non-type 2 or the Th2, if we want to be more specific, and non-Th2 asthma, depending on the cell mediator of the pathophysiology cascade. In general, asthma can be divided into eosinophilic asthma and non-eosinophilic asthma. The eosinophilic asthma, by definition, is an asthma in those individuals who have 2% or at least 2% of their leukocyte count in an induced sputum sample accounted for by the eosinophils. And the eosinophilic asthma per se is divided into an early onset and a late onset. So the early onset asthma is the allergic type of asthma, and it is the most common type of asthma that we see in younger patients. The late onset asthma, or eosinophilic late onset asthma, is the non-allergic type of asthma. On the other hand, you have the non-eosinophilic asthma, which can be either the polygranulocyte or polycellular asthma, and the neutrophilic type of asthma. Neutrophilic type asthma is by definition accounts for about 40% of all asthmatic, and in those patients, at least 40% of the total leukocytes in the induced sputum sample is formed by the neutrophils. So in general, asthma is an allergic disease, and if we want to simplify the pathophysiology, it is a specific allergen that triggers the asthma. The specific allergen is normally taken by the antigen, the antigen producing cell, and this is mainly, or in most cases, the dendritocyte, and this present the antigen to a sort of a naive lymphocyte. This could be either the Th2 in the eosinophilic asthma or other type of T lymphocytes like the Th1 or Th17 in the non-eosinophilic asthma. And then after this, the antigen is presented to the epithelial cells, and the antigen is presented to the T lymphocytes, and then T lymphocytes start to produce certain cytokines, which lead to a cascade of cellular changes and further cytokines production, and these cytokines will be responsible for the symptoms of asthma. Depending on these cytokines and the type of cells producing these cytokines, you get the symptoms. So, for example, for the Th2 asthma or the eosinophilic type of asthma, the main cell mediator is the Th2. This is in early onset asthma is triggered by certain allergens, and after that, it produces the Th2 related cytokines like interleukin 4, interleukin 13, and interleukin 5. Each interleukin is responsible for further cellular changes that lead to the clinical presentation of asthma. Interleukin 4 and interleukin 13, for example, they activate the B lymphocyte, changing the B lymphocyte into IgE producing lymphocyte. Then IgE is produced. IgE will trigger the mast cell, and that leads to mast cell related cytokines release, and these will be responsible for the early symptoms of the asthmatic presentation or the clinical presentation of the asthmatic patient. On the other hand, interleukin 13 also works on a different pathway. It helps, it sort of leads to a smooth muscle hypertrophy and goblet cells hypertrophy, leading to also further mucus production and hypertrophy of the smooth muscles with bronchial constriction. Interleukin 5 is responsible for the activation and chemotaxis of the eosinophils and is a eosinophils-related cytokine release, and these will be responsible for the late clinical presentation of asthma. This is very simply the main pathophysiology for the early onset allergic asthma.
Mm-hmm.
In a similar way, patients or the late onset eosinophilic asthma, the triggers are non-allergic triggers, and the cell mediators will be slightly different. And depending on these cell mediators, the patients will have the clinical presentation. So, for example, in the late onset asthma, interleukin 13 and interleukin 5 are still produced, but there is another cell mediator called the TSLP, the thymic stromal lymphopoietin, which plays a major role in the pathophysiology cascade of the asthma. Knowing these mediators is very important because nowadays in those patients who are on maximum treatment or difficult to treat asthma, we have some what we call biological treatment when we try to attack the cytokine pathway either by directly blocking the cytokine or blocking the receptor of the cytokine, and that leads to a significant improvement in the overall picture of those asthmatics who did not respond to maximum treatment.
Right. You mentioned the late onset and the early onset asthma, and that both of them have specific triggers. Is there sort of an overlap between these two triggers? Because we learned about things like aspirin, for example, being very, very strongly associated with the late onset non-eosinophilic type.
Yes, I mean, in general, to have asthma, you have to have the individual should have the tendency to have the disease. So to be susceptible to have the irreversible airway constriction or to have asthma as a clinical presentation means that you can have the disease either at an early stage or at a late stage. Of course, there is an overlap because certain percentage of patients with early onset asthma, they tend to have a period of remission when they enter adulthood. And after that, either they maintain a very quiet sort of health from the asthma type of view, or they might have a flare or reactivation of their disease as an adult after years of a calm period. And some of these patients, their asthma in adulthood get triggered by totally different triggers or allergens that used to be exposed and to suffer from when they were children or pediatric patients. And now the aspirin or non-steroidal anti-inflammatories in general are specific triggers for asthma. Asthma or the atopic presentation of these patients tend to be slightly different. Those patients tend to have sorts of upper airway type of allergy. They present with difficult to treat asthma on top of nasal polyps and some upper airway allergic presentation. So to simplify the answer to your question, whether there's overlap, of course there's overlap. There's no a clear cutoff or differentiation between the types of asthma, but why we try to phenotype the asthmatic patients is mainly to have a patient-tailored type of treatment because we know that asthma is actually a controllable and not curable disease. So it's very, very important actually to have a patient-tailored type of treatment depending on the specific phenotype.
Hmm. Okay. Thank you, doctor, for the explanation. Hopefully our listeners have a pretty great idea by now of what asthma is and what it does. Let's go back and talk about a classic presentation of an eosinophilic type of asthma. So 5-year-old, for example, family history of atopic diseases. What are some of the hallmark symptoms that tell you as a consultant right away, this is an asthma case? Things like wheezing, for example, is a thing that we see a lot in questions.
Yeah, I mean, the typical presentation of asthma is, as we said, it's mainly a triad. It's chest tightness, difficulty breathing, cough, and wheezing. However, these are very non-specific and not pathognomic for asthma because most of respiratory infections, upper or lower respiratory tract infections or diseases present with cough, chest tightness, and a patient might have wheezing. On the other hand, there are non-respiratory causes for wheezing, and not all asthmatic patients will be wheezy. So to have a high clinical suspicion of asthma on top of having the typical presentation, those symptoms in the typical asthmatic patient tend to vary in intensity from time to time within the same day and from day to day. Patient tends to have more severe symptoms early morning and at bedtime or during the night. So the two ends of the day, either early morning or at bedtime, late in the day, the symptoms tend to flare. On the other hand, patients after some time of experiencing the disease, either the patients or their family members, if they are young children or pediatrics, they start to know exactly what triggers their symptoms. So each patient has a specific trigger. This could be, environmental change, dusty days, rainy days,
Food allergies.
food, sometimes specific, fumes, odors, certain allergens. Sometimes the asthma flares up whenever there is a viral illness or flu-like illness. So having this triad or this clinical presentation triggered by a specific trigger having a variability of the intensity of the clinical presentation, having a family history because asthma tends to run in families, having other atopic diseases either individually or in the family. All these can raise your clinical suspicion of the disease or of asthma as a disease.
Okay. So now we have our suspicions raised. What can we do to confirm this disease?
Yes, of course. In general, yeah, as a physician, to make the diagnosis for any disease in general, it's history, physical examination, and tests or confirmation of the disease. So we've mentioned the typical clinical presentation. So if you have somebody who is presenting to you with a typical clinical presentation that makes your clinical suspicion of the disease quite high, so then the next step is to take detailed history, extend, the information about the patient, all the circumstances that we've mentioned. Take a personal history, ask about the triggers, ask about specific triggers that the patient himself might not offer, like medications, exercise for adult patients, occupation exposure. And then take detailed family history, ask about the presence of asthma in the family, presence of any atopic illness in the family, and then do detailed physical examination. Now, the physical examination of an asthmatic patient outside exacerbations can be completely normal. However, the most frequently encountered sign is the wheezing, which is normally an expiratory wheeze that can be heard with auscultation and more pronounced with forced expiration. But not having wheezing does not exclude asthma, and wheezing is not pathognomic for asthma. So having a typical clinical presentation and wheezing on chest examination does not rule in asthma 100%. You still need to confirm asthma. As we said, by definition, asthma is a reversible airway contraction. So you need to simply to confirm spirometry or detailed lung function test and confirm that the patient has got a reversible obstructive airway disease. Reversible obstructive airway disease, very simply, patients with asthma during the attacks, or if they are symptomatic, they will have the obstructive pattern. That means there will be a reduction in their forced expiratory volume within the first second over the forced vital capacity. So the ratio, the FEV1 to FVC ratio, should be less than 70%, and this should be reversible, not fixed obstruction. So the reversibility could be either, as we said, spontaneous. So if you do this spirometry on the same patient at in a different setting when they are asymptomatic and you have completely normal spirometry, that is per se. So if you have a patient who is presenting to you with two different spirometry, one done when he or she is symptomatic and the other one done when he or she is asymptomatic, and there is a reversibility, clear reversibility that confirms the disease, or you can do or test the reversibility by offering these patients, treating them, medicating them with bronchodilators, short-acting bronchodilators, inhaled or nebulized, and then repeating the same test and confirming that there is a reversibility. The cutoff for the reversibility is an improvement of the FEV1, the forced expiratory volume within the first second by a minimum of 12% and 200 ml of the absolute number or the absolute figure of the FEV1. Previously, we used to say 12% or 200 ml. The criteria for confirming the diagnosis or the confirming the reversibility is a 12% and 200 ml of the absolute number improvement to bronchodilators. Of course, this is the typical test, but there are some other ways also to confirm reversible airway disease or to confirm asthma. For example, you could do it the other way. You could do a spirometry and then get these patients to exercise and to repeat the spirometry exercise tends to reduce the FEV1 in most asthmatic patients, mainly those younger patients who have exercise-induced asthma. So if there is a reduction, 12% or 200 ml reduction of the FEV1 with exercise, that is also a indirect confirmation of asthma. Or you could simply treat these patients with a course of steroids, bring them back, and do the spirometry. And if there is an improvement in their spirometry, if they meet the criteria for the improvement, then they have asthma. Or you could simply ask these patients to do peak flow meter at home. If you don't have access to spirometry, just give them a peak flow meter, peak expiratory flow meter, ask them to check their peak flow on daily basis on two different times during the day, and check for the diurnal variation. Those who have at least 20% of diurnal variation for most days on a week of a regular measurement, this is also indirect confirmation of asthma.
Mhm. Right, so it could work both ways. It could either be an increase of 12% or a decrease, depending on whether we're inducing bronchoconstriction or bronchodilation.
Absolutely, and this is the main principle actually for
Right.
the only confirmatory test of asthma, because all these are not confirmatory tests. So even the spirometry is not a confirmatory test, because somebody might come to you saying that I am on treatment for asthma, I've been diagnosed with asthma, they are completely asymptomatic, and they have no signs, they have complete normal physical examination, and you do spirometry and they have completely normal spirometry. That does not mean that they are not asthmatic. Patients outside the asthma symptoms or the asthma exacerbation, they are completely normal individuals.
Right. This is where I think a lot of the confusion comes in with students, because when we're talking about chronic obstructive pulmonary diseases, it's such a heavy term. We expect there to always be symptoms, throughout. So it's different when you have a patient who's sort of has exacerbations and sort of back to baseline.
Yeah, of course. I mean, there's a lot of confusion between the by far the two most common airway diseases, the asthma and COPD. There's lots of overlap in terms of a clinical presentation, in terms of how we manage these patients. So that's why it's very important for the students to be quite clear how to differentiate between these two syndromes.
Mm-hmm. Okay, could you talk to us a little bit about what the methacholine challenge test is?
Yeah, this is what we said, because I mean, you rightly highlighted that we can confirm the asthma both ways, either by an improvement or worsening. So what you need to confirm that the airways constriction is reversible. Okay, either if they do have a constriction, then it is reversible with treatment or with time, or if they have completely normal, they can offer or exposing them to trigger can lead to constriction, and that improves with bronchodilators. So this is the general idea behind the methacholine challenge test. So methacholine challenge test is the only, and this is what all students need to know, all physicians need to know, is the only confirmatory test. Okay, so this is the confirmatory test and the only confirmatory test for asthma. However, we do not do this test quite often, because most of the time we rely on the clinical presentation and the evidence of the reversible airway to confirm asthma. But let's take an example, somebody who presents with symptoms highly suggestive of asthma. So you have high clinical suspicion of asthma, and you started these patients on treatment, and there is no significant improvement. They are still symptomatic on and off, and they are compliant. You've checked the technique and everything seems to be okay. However, these patients are not improving. You've done the spirometry and you could not actually catch these patients when they do have bronchoconstriction. So you don't have any confirmation in terms of spirometry, peak flow meter, that these patients do have a reversible airway constriction. So you're still in doubt, and this is when we send these patients for the methacholine challenge test. So on an average, probably once or twice per year, we need to ask for this test. So the whole idea is to expose these patients to a well-known vasoconstrictor agent and to check their spirometry. So to have a baseline spirometry or pulmonary function test, which is in these individuals completely normal, and then to expose these patients to an incremental dose of a well-known bronchoconstrictor like the histamine or the methacholine, and then repeat the spirometry or the pulmonary function and confirm that they have reacted to this vasoconstriction by a 20% reduction of their first expiratory volume within the first second.
Right, right. So we've learned about methacholine challenge test, spirometry, PFTs, all these tests to raise our suspicion for asthma, and then obviously the methacholine test to confirm it. There are a whole bunch of other tests that we also learned, things like seeing eosinophilia on a CBC, things like skin allergy test, exhaled nitric oxide.
Yeah.
How often are these used in a clinical settings, and are they specific in any way?
They are specific, but they are not commonly used. They are used by the specialist.
Mhm.
Okay. So it's nice for you to know about it, but these are not tests for the general physicians. These are not tests for the internist. These are tests for the pulmonologist. In general, the idea about performing these tests is to phenotype the patient, i.e., to decide whether these are eosinophilic or non-eosinophilic, because that is a major decider of how you treat these patients.
Mhm.
And it's also a very helpful method to decide in the future whether you need to add a biological treatment, and when you add a biological treatment, to confirm or to help you to choose between these biologics. So amongst these tests, which are specific tests, and these are not essential to confirm the diagnosis, but to phenotype the asthmatic patient, is to check for eosinophilia. So once asthma is confirmed, we tend to send these tests for all asthmatic patients upfront before start treatment, because treatment can affect the outcome of the differentiation for the complete blood count. So we tend to send for CBC and differentiation to check for eosinophilia. We also check for IgE level. Again, as we said, the early onset asthma is an allergic eosinophilic, so we check the level of the IgE, because if it is high, that means that these patients are in this group, which is the early onset, the allergic eosinophilic. We can also send for specific IgEs if we have a suspicion of specific trigger, like having a pet at home, a cat or dog, or living in a rural area when there is an exposure to certain type of flowers or plants or type of animals. So you can send for the IgE subtype. So and check whether you or try to allocate the specific trigger, because that can help to advise the patient to eliminate this trigger. Amongst the other tests that we can do is the fraction of inhaled nitric oxide,
Mhm.
because it tends to be high in those who have eosinophilic asthma. It is a very simple test and very useful actually to phenotype patients.
Right. Okay. So I'm going to try to tell you what I sort of understood from the diagnostic management of asthma, and then if you could just tell me if there's
Sure.
anything that I'm missing. So we have a patient with suspected asthma. We're going to start with spirometry first. If the pulmonary function tests show like an obstructive pattern, we can give a bronchodilator and then repeat the spirometry. If the forced exhaled volume in the first second is increased by 12%, or and by 200 milliliters, it confirms the diagnosis, and then we can start with a round of corticosteroids. But if the pulmonary function tests are normal, that's when we would do the methacholine test.
Yes, this is in general. But what we need to bear in mind that methacholine challenge test or the provocation test in general, either methacholine, histamine, or dopamine, or whatever airway provocation test is. This test is very specific, and not every physician or not every pulmonologist will have an easy access to such a test. This is one. It is an expensive test, and it takes time, effort, and needs direct medical supervision. So it is not a technician who can do
Right,
it.
of
So you
course.
need a pulmonologist to be present at the time of the test. And on the other hand, it can trigger an asthma flare-up on an asthmatic patient. So the alternative way is actually to start a treatment trial. So if you have somebody who is presenting with symptoms that makes the clinical suspicion of the disease high, and they mentioned wheezing, or somebody, in their records, wheezing has been mentioned. There are specific triggers. They have a variability in the disease. They have seasons when they or day or days or times during the day when the symptoms. So everything is pointing towards asthma. You did spirometry, and your spirometry is completely normal. So you are now in doubt. So you can feel the alternative to send them for methacholine challenge test is to start them on a treatment and then reassess the response. If there is a positive response, that is indirectly or retrospectively a confirmation of disease. And this is within the guidelines. So it is a recommended method of confirming the diagnosis as per the GINA and CINA.
Mm-hmm. Right. Okay, perfect. Now, let's say we've diagnosed this patient with asthma. How do we go about the treatment plan? And could you sort of explain the step by step, the ladder, I guess, treatment of asthma?
Yeah, it is a bit complicated. Of course, you don't need to know every single detail of each step. All what you need to know as medical students or even general physicians, that the management of asthma is not fixed. So it is a stepwise management, and deciding on what step you start the patient, you have to stratify the severity of the disease, and based on the severity, you can start the patient on the treatment. On the other hand, what you have to understand that the severity of the disease is not sustainable. So those who have mild disease might have moderate or severe disease in the future, and those who have severe or difficult to treat asthma might have periods when their disease turns into moderate or mild, or they can go into remission. So it is a dynamic treatment, and that's why GINA had a stepwise or a cascade of management. It is a stepwise, starts from step 1 and ends in step 5. In general, how do you decide on the intensity? For those who are treatment naive, you start them on treatment and you adjust the treatment until you reach remission. When you have reached the remission and you manage to sustain the stability, the clinical stability, for enough period of time, normally for about 3 months, then depending on how much treatment they needed, you can stratify the disease as mild, moderate, or severe. Those who need step 1 or step 2 of the management cascade, the disease is considered mild. Those who need step 3 of management to stabilize their disease, the disease is considered moderate. Those who require step 4 or step 5, the disease is considered severe. In general, for those who will have an extended reading or read the GINA guidelines or look at stepwise, the stepwise has 2 rules, or actually it divided into preferred treatment and alternative treatment. And asthma management in general is divided into the control medications and symptomatic or reliever medications. So each asthmatic patient should have a controller and a reliever. They are normally inhaled medications because this is the preferred type of management. So we hardly treat any asthmatic patient with systemic medications. It's normally an inhaled medication, i.e., each asthmatic patient should have a controller inhaler and a reliever inhaler. Now, for those who are on step 1 or step 2, that means for step 1 and step 2, that means those who have mild disease, the reliever and the controller can be combined in one device. They can be used as and when needed on PRM basis for step 1. Step 1, those who have very mild disease, they have symptoms of once or twice per month without any risk for exacerbations. So those who have very mild disease, they require only step 1. They can have these combined in inhalers, the controller and the reliever in one device, and they use it as and when needed. If they are not responding, or those who have slightly more severe disease, those who are on step 2, they use the same inhaler but regularly, and they can be used, the same inhaler, the combined inhaler can be used as a reliever and controller at the same time. Alternatively, the alternative type of treatment is just to separate the inhalers and give them the reliever and the controller. For step 1, they can use the reliever and controller on PRM basis. For step 2, can be use them regularly. When we say controller, the controller is always inhaled corticosteroid, and you can add to that controller when the disease severity gets higher and higher. But the mainstay controller is the inhaled corticosteroid. Either we increase the dose of the inhaled corticosteroid or we add medications to achieve control. The reliever is a bronchodilator, and the bronchodilator could be either short-acting or long-acting bronchodilator. The short-acting bronchodilator is normally to provide an immediate relief. The long-acting bronchodilator is normally added to the inhaled corticosteroid in those who have more severe disease, starting from step 3 onwards. So if a single message has to be taken from this entire subject, i.e. the treatment or the asthma treatment, I want everybody to understand and to realize that once asthma is confirmed, asthmatic patients should be started on inhaled corticosteroid. No asthmatic patient should be off inhaled corticosteroid, regardless whether they use it as and when needed on PRM basis, once a month, once a year. But an asthmatic patient need to be on inhaled corticosteroid. That has to be used depending at a frequency depends on the severity of their disease.
Right. So just to reiterate, the milder forms would be controlled with the controller inhaler, which in this case would be an inhaled corticosteroid always, and it could be either a short-acting or a long-acting. When do you make that decision of whether to choose?
You mean the inhaled corticosteroid? There's no short-acting or long-acting.
No, I'm sorry. The additional.
The reliever, the bronchodilator.
Yes.
Okay. So it's short-acting is the reliever, the immediate reliever. Okay.
Right.
So across the management cascade, there will be always short-acting bronchodilator, which could be either a short-acting beta agonist or short-acting muscarinic antagonist.
Right.
So either SABA or SAMA. Okay. Now the long-acting beta agonist, we start to add it to the inhaled corticosteroid starting from step 3 onwards.
Okay. Right. Okay. But in all cases, we should at least be having the inhaled corticosteroids and then the SABAs or the SAMAs.
Yeah. I mean, somebody might come back and say, oh, okay, doctor, but I mean, we read that on step 1 or step 2, you can add certain type of long-acting beta agonist to inhaled corticosteroid in a combined inhaler. So we can add formoterol to the inhaled corticosteroid and use it in step 1, step 2. And you said that, and formoterol is long-acting beta agonist, and you said that long-acting beta agonist starts from step 3. So how come it is on step 1, step 2? Yes. Formoterol per se has a very specific pharmaceutical features that it works as a short-acting and a long-acting.
Okay.
So when it is added to the inhaled corticosteroid, it is added for its short-acting effect.
Right.
Okay.
Right.
So the formoterol in step 1 and step 2 is not used as a long-acting bronchodilator. It is mainly used for its short-acting effect as an additive to the inhaled corticosteroid.
Right. Okay, and when do these other drugs like Zileuton, for example, or omalizumab, these other biological agents, when are they used?
These are for those who are on step 5 and still not controlled.
Wow.
Step 5 of the management is the maximum pharmaceutical management that you can offer a patient. That means those patients will be on high dose inhaled corticosteroid. They will be on long acting bronchodilator, so they will be on LABA and LAMA, and they might be also on leukotriene receptor antagonist like the Montelukast,
Montelukast.
and still symptomatic. Of course, when you have somebody who is on maximum treatment or on the right treatment as per your severity assessment, and they are still not responding, so there are few things that you have to check. Of course, first is the patient compliance, which is a major decider of the response. So you need to make sure that, because asthma is a chronic disease. It's a
Right.
disease that the patient will live with. Most asthmatic patients are young, so they can be either children or teenagers. Those people are very, very difficult actually to control. They are full of energy and they don't like to be restricted by using medications on daily basis. So you need to make sure that the patient understand the disease, have enough insight of their disease. They can have self-control or self-monitoring of their disease. They are compliant to the medications. You have to test their technique. So you have to ask them to use the inhalers whenever you see them in the clinic, whenever they come for their follow-up. And the last thing is try to eliminate obvious triggers. Somebody who has a cat and tested to have very high IgE, specific IgE for cat or specific IgE for dog, for those who have dogs, or specific IgE for the trigger that they have as a household. So you've eliminated the trigger if possible. You've checked the technique and it is appropriate, and you are sure that they are compliant. Then that means they are difficult to treat asthma. So they meet the definition of difficult to treat asthma. And this is when you consider adding biological treatment. It's very tempting actually, because now, we get excellent results with biological treatment. It's very tempting to use it upfront, but this is not the general direction.
They're very expensive too, I heard.
It is expensive. It is not a complication or side effects free. And because it's not widely available medications, so general physicians or healthcare providers should not be encouraged actually to use these medications so easily.
Right. You mentioned a little bit about this when you mentioned, like, for example, getting rid of a pet when you want to limit the triggers. Do lifestyle changes play any sort of role in asthma management?
Of course.
Yeah, like smoking cessation, for example,
Of
for
course.
older patients.
Of course. Asthma is not a smoking-related disease.
Right.
So it does not play a role in the pathophysiology of asthma. However, smoke exposure, so cigarette smoke exposure, is well-known trigger of asthma. And that's why we highly encourage asthmatic patients to stop smoking, because this could be simply the trigger of, of the disease, or to try to avoid smoke exposure. So if he or she lives, because you encounter lots of asthmatic patients when the wife is asthmatic and the husband is a smoker, or the other way around, or somebody who works in an environment when everybody smokes and they don't smoke, but they get triggered, they get their asthma triggered by the exposure. Yes, changing the lifestyle is important. We encourage, as we said, avoidance of smoking exposure. If there is a specific well-known trigger that has been tested, so if possible to try to get rid of the trigger. For those who have occupational asthma, and that has been proven, so we advise them to change occupation. We provide them with reports, even medical reports, advising the supervisors to change their environment, work environment, to try to improve the disease. Overweight or obesity also can be a trigger, mainly for the non-eosinophilic type of asthma or the neutrophilic type of asthma. So weight reduction can help. And exercise, try to live a healthy life, also helps in health in general, and of course help asthmatic patients to improve their disease.
Okay. So what if we have a patient who's a known case of asthma and they come to your clinic with an exacerbation? So they have severely low, for example, oxygen saturation. How would you go about treating them?
You mean how to treat an asthma exacerbation or
Yeah.
asthma flare-up? Yes, I mean the general principles is actually to ensure the well-being of the patient. Unfortunately, I mean, despite the asthma, we have an advanced knowledge of asthma. We have very advanced medications that can treat asthma. And most or the vast majority of asthmatic patients, they have a modest type of disease, and the disease can be controlled with medications. So despite all this advancement in the way that we treat or manage asthma, we are still unfortunately facing some tragedies, and there is still a well-documented asthma-related deaths or asthma exacerbations-related death worldwide. And most of the casualties are related to the exacerbations or to the flare-ups. So it's very important for the healthcare provider to know how to manage the asthma exacerbation or the asthma flare-up, and to know his or her limitations, and to know exactly when to refer the patient to the higher center for management. So that means when you see somebody with flare-up, you have to think of, one, how bad their flare-up, stratify the severity of the exacerbation, and at the same time initiate the treatment and decide whether you can finish the treatment. You can initiate and finish the treatment at your level, or whether you need to make an immediate attempt to transfer the patient to higher center.
Right.
So in general, there are certain criteria to stratify the disease severity, decide whether it is mild/moderate exacerbation, severe exacerbation, or life-threatening/fatal exacerbation. For life-threatening and fatal exacerbations, these need to be treated with the well-equipped higher centers. So they need to be treated in an emergency environment, in hospitals or in health centers that they have emergency and access for ventilation, intubation, whatever it takes to manage these patients. But for the general health care provider, mild, moderate asthma can be treated and finished with the healthcare provider unless the response wasn't optimal. How we start the treatment after we stratify the severity and decide whether we need to make attempt to transfer these patients to the emergency or treat them entirely in the primary care setting. We start the treatment with bronchodilators. So these are short-acting bronchodilators, short-acting beta agonist, the albuterol, either inhaled or nebulized. We tend to repeat the dose every 20 minutes for the first hour. We also give them one dose of short-acting muscarinic antagonist,
Right.
the ipratropium bromide.
Mm-hmm.
And if they are hypoxic, we give them oxygen to keep their oxygen saturation within normal range, so 94% or above. And if you have access to systemic steroids, we give these patients steroids, either oral, IM, or IV. Those patients have to be assessed after 1 hour of management. If there is a significant improvement and they are beyond the cutoff for deterioration or for disease severity, i.e., their peak flow meter measurement is above 60% of their best or their predicted, that means it's safe actually to keep these patients with you.
Mm-hmm.
And if they are significantly better, you can even escalate their management temporarily and discharge them. Make sure that you give them a short follow-up within the next few days, either with you or with the asthma specialist nurse.
Mm-hmm.
And then during your follow-up, you can decide whether you can bring them back to their level of management or whether you still need to continue with the higher intensity level of treatment for a bit longer.
Mhm.
After 1 hour, if they are not responding, then you need to make sure that you transfer them to the
Right.
to acute setting.
Right. Why is it that we opt for other routes of delivery of the steroids in an acute exacerbation? So usually we would do inhaled corticosteroids. Why is
Yeah.
it that we go for IV or IM?
For more than one reason. Because I mean, as we mentioned, exacerbation is actually a medical emergency and
Right.
has to be managed seriously, taken seriously, because there are casualties related to the asthma exacerbations depending on the severity. So that's why we try to use the most effective treatment. And as we mentioned at the beginning of today's podcast, that asthma is a chronic inflammatory airway disease.
Mm-hmm.
And these exacerbations is just a flare up of the inflammation. So there is an acute inflammatory process that had led to the exacerbation. So giving steroids is essential. So why do we decide on a different route? Because we need a quicker bioavailability,
Okay.
and giving the corticosteroids systemically, either parenteral or oral,
Right.
will lead to a better bioavailability. On the other hand, the dose that we use is totally different. The inhaled corticosteroid dose is a fraction of what we use during the acute exacerbation systemically. So we need much higher dose that cannot be provided through the inhaled route, and we need quicker bioavailability, which cannot be also provided through the inhaled route. And lastly, during exacerbation, those patients will be tachypnic. Some of them will be very tachypnic, and the administration of the medication via an inhaler or nebulizer will be affected by their tachypnea. So that means due to the tachypnea, they won't be able to take enough inspiratory flow to provide the inhaler, or to take the inhaler and make sure that the inhaler is well distributed to the smaller airways.
Mm-hmm. You mentioned some different ways we have of measuring the disease severity in an acute asthma exacerbation.
Mm-hmm.
Could you name a couple, and maybe what's your favorite one to assess in the clinic, the most specific one?
I can go through most of these because I mean they are very simple.
Mhm.
I mean, the abilities to talk in phrases or in words. So if the patient is able to take in phrases, that means the disease severity is less than those who can talk only in words during one breath. Able to lie back or being restless, prefers to sit forward, tachypnea, tachycardia,
Right.
and the most actually accurate parameter amongst all, because most of these are just clinical, but the most accurate is the peak flow meter,
Mhm.
if the patient is able, because as we said, some of these patients will be very tachypnic, so it will be very difficult for them to be tested or to do an accurate and appropriate peak flow meter measurement.
Right.
Yeah.
Right. I think the one thing that stands out to me is the tachypnea. I'm assuming, or I'm expecting, because they're tachypnic, for the partial pressure of CO2 to be pretty low. They're blowing off a lot of carbon dioxide. But I did read somewhere that high CO2 would be like a bad sign for an
Yeah,
asthma exacerbation.
I mentioned that those who have life-threatening asthma / near fatal asthma are those who have to be transferred immediately to an acute care setting when their exacerbation is managed. So those patients, when they present to you, they are really exhausted. They might even have a silent chest instead of severe wheezing.
Mhm.
And the difference, or the main difference between the life-threatening and near-fatal asthma, is actually the level of CO2.
Wow.
So if somebody is coming exhausted with a change in the consciousness level, have silent chest, clammy sweating, this is by definition a life-threatening asthma. Now, if you've done the blood gases and they have normal or high CO2, because we do expect those patients to have low CO2, low partial pressure of carbon dioxide. If they have sort of high normal or high CO2. That means their expiratory muscles, the respiratory muscles, are exhausted and they are starting to retain carbon dioxide, and that changes their classification or the severity classification into near fatal.
Mm-hmm.
So those patients are at much higher risk. They need to be treated, as I said, in acute setting. Intensive care have to be directly involved in their management, and if it takes to even give them muscle relaxants and intubate them temporarily, we do to save their lives.
Right, whatever it takes.
Yeah.
Okay, so now on to the segment that I think a lot of our listeners should hopefully be looking forward to. And if you weren't paying attention before, I really hope you do now. If all of this comes as an OSCE station, doctor, what sort of advice do you have for the students to pass?
Right. Yeah. This is maybe my favorite part, because I mean I'm heavily involved in students' OSCE. I sit in every OSCE, and it happens quite frequently that I'm the examiner for the asthma station.
Mm-hmm.
And I've been giving actually the asthma lecture for a number of years now. So I tend to blame myself when people do not do well. So it's very strange that lots of your colleague actually when they come to asthma, they just get confused. So of course, when we test the students in the OSCE on asthma case, we try to make it slightly atypical. So you wouldn't expect that we tell you that this is somebody this is a patient from a family known to have asthma, and he's coming to your clinic with wheezing, chest tightness, and cough, and has been taking some inhalers but did not improve. So take further history. The presentation will be slightly different, but you have to have an open mind. You have to be vigilant that asthma can present with atypical symptoms. So a young patient, a student or a university student who is coming with few months history of cough, and we ask you to take history. So it is now down to you to start to dig deeper in the history and decide whether this cough is due to asthma or not. And it's very actually, at least to me, it's very surprising that, clearly you tell the examinee that this is a young, fit, well, healthy patient who is coming with 6 months history of cough, and then their attention goes completely to a different pathway, and they start to ask about alarming symptoms. And when you ask them about differential diagnosis, they come with lung fibrosis, lung cancer, CF, cystic fibrosis, in somebody who never had symptoms until they are late teenagers. So what you needed, just to make it simple, always, as a general advice, common things are common. But for whatever reason, medical students always think of the, most rare conditions rather than thinking straightforward.
Yeah.
The exam is not actually meant to trick you. It's actually to help to assess your knowledge. But we try to help your common knowledge, not your rare knowledge.
Right, yeah.
Okay? So always think straightforward.
Mm-hmm.
So the first thing comes to your mind is normally the right thing. Okay?
Yeah.
And common things are common. When somebody is coming with cough, okay, so they must have, and this cough has been there for the last 6 months. It cannot be pneumonia. And every single student, when you ask them about the differential diagnosis, they will tell you pneumonia. What pneumonia that takes 6 months to recover? Or they tell you lung cancer in 16-year-old. Yes, I mean, it's not unheard of,
Right.
but it's not common. Okay, we will not ask you about, the 0.01% likelihood of occurrence. We'll ask you about the most common type of occurrence. So somebody is coming with cough, start to ask about, other symptoms.
Mm-hmm.
This patient has got wheezing, been treated with inhalers, but we've hidden this information for you to ask about.
Right, for us to find out.
Take deeper history. Okay, ask the patient, ask the candidate there who is the patient, ask them whether they have any other symptoms, whether they had childhood disease, whether there's any family member who has asthma, whether they had inhalers before and they responded and they have stopped taking these inhalers, whether there's any specific trigger, whether they are known to have any other atopia, like eczema or like allergic rhinitis. Ask them whether they keep pets at home. Ask them about their, lifestyle, the environment that they live in,
Hmm.
and then after some history, tell that, oh, okay, start to examine these patients, okay? And then we will start to offer you the symptoms or the possible the possible signs that you might encounter during the examination. Or I'll tell you, okay, examination is completely normal. And then simply we move to the next step and say, okay, now this is somebody who is coming based on your information, is coming with cough for the last 6 months. Based on the information that we've offered you, give me the differential diagnosis.
Hmm.
And now you have to be very logic in your differential diagnosis. Otherwise, it's very irritating.
Right.
So yes, I would say, okay, asthma, allergic rhinitis, because they are very interconnected. So asthma and allergic rhinitis are the top two differential for chronic cough. What else can give you chronic cough? It could be acid reflux disease.
Right.
That can
Yeah.
gives you chronic cough.
Mhm.
Okay. And lastly, if you want to say that this is an idiopathic chronic cough, fine. Maybe this patient has got bronchitis due to childhood infections. It is acceptable, but do not go, very diverse in your differential diagnosis,
Right.
because common things are common. Okay, once you say that asthma on the top of the differential, that gives you, high opportunity of not only passing this station, but even, scoring high because you are on the right direction.
Hmm.
And depending on your differential and the list of your differential, we'll say, okay, what are the tests that you need? Very simply, all what you need. Somebody is coming with, if I ask you now, okay, I'm your patient, you are my
Mhm.
physician, I'm coming to you with a cough for the last 6 months.
Okay.
Okay. So I want you to choose 4 tests, okay, which are specific for my presentation. So this is what we ask. She says, I want to send the patient for blood test. Okay, what blood test do you want? I want to do liver function test. Why liver function? This is somebody coming with cough.
Right.
Okay, what else? Okay, I want to do a kidney profile. Fine. What else? I want to do the iron profile. And then it starts to be very irritating.
Right.
I want to do CBC. Fine. Okay, at last, there's something correct. You
Mhm.
want to do CBC. Why? To check whether he has an infection. So even when they say something
They're
right,
saying it for the wrong
they,
reason.
they, they say it for the wrong reason.
Yeah.
I want to do CBC to check for eosinophils. I want to do CBC and differential. Why the differential? To check for neutrophils to see whether he has got an infection. No,
Hmm.
no infection lasts for 6 months.
Right.
We decided that this is not infection. So CBCD, fine. Okay, you will get marks for only if you mention 3 right investigations, you get full mark.
Okay.
Okay,
Mhm.
so CBC with differential. Okay, what else would you do for this patient?
Like pulmonary function tests.
Fine, spirometry
Spirometry.
or big flow meter. What else?
For a chronic cough,
Yeah.
we could do an X-ray, maybe.
Yes, and you can imagine that 80%, 80%. I've done in one of the OSCEs. I've just done a simple calculation. 80% did not mention chest X-ray.
Mm.
Okay, and what's more irritating, some of the students said CT scan without chest X-ray. So they want to send the patient immediately for CT scan without doing chest. So my advice: think simple. I understand. I've been a student. I sat too many exams. It's you will be very anxious. Okay, thinking of the previous station and your next station, and to finish on time and not to do any mistakes. It's not about throwing all the answers,
Hmm.
because throwing too many answers does not give you high mark.
Right.
But saying the right answer, okay, that gives you the mark.
Yeah.
Okay, so think simple. Chronic cough, somebody who's presenting with a respiratory condition, they need to have a chest X-ray. Definitely, they need to have a chest X-ray.
Of course.
Okay, and then try to direct the other investigations towards your differential diagnosis.
Hmm.
Okay.
Yeah. This is like the top tier of medical students, is to accidentally miss something. So it takes years of conditioning, but I think by now the way we study for OSCEs is just like you mentioned, we try to throw out every answer we could possibly think of before we even start thinking of what it could possibly be. So CBC,
But you
LFT,
don't
RFT,
you don't
TFT.
get marks of
Yeah,
how much answers that you
of
provide.
course.
Your mark is for the correct answer.
Hmm.
It doesn't matter whether you tell me, I tell you give me a differential diagnosis and you give me 12 differential diagnoses, one of them is right and the other 11 is wrong, you won't get marks for the other 11. Okay?
Right.
Instead, I mean, here we don't have negative marking, okay, but I mean, all of you, inshallah, in the future, you will sit international exams. In the international exams, sometimes if you irritate the examiner, your exam stops there.
Oh, wow. Right. Okay. All right. Thank you so much for the insight. If we could pivot a little bit and start talking more generally about chronic obstructive pulmonary diseases.
Okay.
We know things like emphysema and chronic bronchitis and how they can sort of overlap. But could you tell us a little bit about the difference between those two subtypes?
Yes, of course. Of course, as a medical student, you need to know the different of these subtypes.
Mhm.
In general, practically speaking, we do not now pay much attention about chronic bronchitis and emphysema as two different parts of COPD. For the last maybe 15 years, we treat them as one syndrome and we call them the chronic obstructive airway disease because management prognosis in general is the same. Okay.
Mhm.
However, there are differences between chronic bronchitis and emphysema. Both of them are under one umbrella, which is the chronic obstructive airway disease umbrella. In general, if we want to talk about pathophysiology, chronic bronchitis is a chronic neutrophilic inflammation of the intermediate and small airways, leading to an excessive mucus production that leads to mucus plugging and airway narrowing due to the mucosal edema
Mhm.
and the thickening of the airways, the intermediate and small airways. So patients with chronic bronchitis tend to have chronic productive cough. And if you want to specify that under a definition, chronic bronchitis is defined, or the definition of the chronic bronchitis is a clinical definition. It is defined as cough and sputum production for a minimum of 3 months per year for 2 consecutive years. And it doesn't matter whether they cough for 3 consecutive months or in consecutive months over the year.
Mhm.
But in general, it is a persistent chronic productive cough that lasts for more than 2 years. On the other hand, emphysema, the definition is a pathological definition, is not clinical. So it is an alveolar destruction that leads to air trapping, hence the word emphysema. So those patients, due to whatever trigger they get exposed to, they plus the genetic predisposition, they have alveolar damage that leads to difficulty in exhaling all the inhaled air, leading to a dynamic trapping, which will lead to the clinical presentation or the clinical symptoms that they suffer from.
Mhm. Right. We always, when we study chronic bronchitis and emphysema, we study them separately. So sometimes we can hear things that sound like they sort of contradict themselves. Like, for example, bronchitis, the buzzword that we always hear is blue bloaters
Yeah.
because they have this air trapping and so on, and they have insufficient oxygenation, and then they're going to get cyanosis.
Yeah.
And they tend to be on the heavier side too, so then we call them blue bloaters. And then on the other hand, emphysema, we call them pink puffers.
Yeah.
So what exactly is the...
Right. Of course, now the emphysematous patients or patients with emphysema, as a phenotype, they can be called as the pink puffer.
Mhm.
That the patient they don't have cyanosis.
Right.
Those patients tend to have, on the other hand, they tend to look pink. You measure, despite that they are very symptomatic, but they will have sort of normal oxygen saturation. They don't tend to be hypoxemic.
Mhm.
So they are not cyanosed, they're not hypoxemic, but on the other hand, they are quite symptomatic. They are dyspneic, they are tachypneic. They tend to be underweight with some muscle wasting. And as a disease background, they do have emphysema. As we said, the emphysema is actually a destruction of the alveolar walls, and that leads to air trapping. The air trapping will lead to a dynamic increase in their residual volume.
Mm-hmm.
However, those patients do not have a VQ mismatch
Okay.
because the underventilated areas will be at the same time underperfused areas.
Right.
Okay, so they will have sort of a VQ, a matched ventilation perfusion. So the areas with the alveolar destruction, these areas will subsequently, because of the lack of the ventilation, the destruction will also involve the vascular bed.
Okay.
So the damage will be for the entire alveolar area.
Right.
Okay, so there will be a deficiency in the ventilation
Perfusion.
and perfusion, and that's why, because there's no mismatch, okay, VQ mismatch, so they don't have the hypoxemia,
Mm-hmm.
okay, and they will not be hypercapnic until they reach very advanced stage. Now, to overcome these hypoventilated areas due to the emphysematous areas, the emphysematous patients tend to compensate by hyperventilating.
Right.
Okay, so chronic hyperventilation used to a chronic usage of their muscles,
Right. Muscle
and
wasting.
that's why they look pink, and they have with time muscle wasting. Okay, so they look thin. So they are quite symptomatic, and they falsely give you an impression, because when you measure their oxygen saturation, their pulse oximetry, it will be within normal. They give you false impression that they are fine.
Mm-hmm.
However, they are quite symptomatic. They are just compensating for the deficiency. On the other hand, the main, as we mentioned for the chronic bronchitis, the main pathophysiology is the overproduction of the hypertrophy of the goblet cells, the hypertrophy of the epithelium of the intermediate and small airways due to the chronic neutrophilic inflammation. And those patients will have excessive mucus production and mucus blogging. So their alveoli, so the gas exchange surfaces, are intact.
Right.
But due to the mucus blogging and the intermediate and small airways, there will be no airflow to these areas,
So
to the
poor ventilation.
intact alveoli. So there will be lack of ventilation with intact perfusion. The alveoli are intact, but there's no air reaching these alveoli. Okay,
Mm-hmm.
so there's significant VQ mismatch in these patients. Okay,
Right.
again, the emphysema tend to be heterogeneous, so the destruction of the alveoli in the emphysematous patients is patchy, and
Right.
that's why emphysema can be either central-lobular or
Pan.
paraseptal, or some of them they have diffuse emphysema. But while the chronic bronchitis tends to be diffuse, so you will have the mucus blogging almost widespread in both lungs, with areas more affected than the others, and that will lead to a significant VQ mismatch.
Mm-hmm.
So these patients will be significantly hypoxemic, hypercapnic, they are cyanosed, but they are not very symptomatic.
Right. And just if I can ask a further question, now our body has a natural way to sort of protect us against those poorly ventilated areas through the hypoxic vasoconstriction. Does that also exacerbate the cyanosis seen in bronchitis, since you're shunting all of that blood to the left
Yeah,
to the left heart?
yeah,
Okay.
yeah, definitely.
So that is the
Yeah,
pathophysiology.
yeah.
Okay. So there's also one other thing that a lot of our students tend to get confused on, which is the diffusion coefficient, like the DLCO,
Yeah.
in that it is decreased in emphysema, but it could be normal in other
Of course, of course.
subtypes.
Yeah,
Yeah.
of course, because I mean, the DLCO depends on the gas exchange service.
Hmm.
So the gas exchange service, if I ask you, what part of the lung is the gas exchange service?
Right, the alveoli.
The alveoli. So if you have any defect at the level of the alveoli, either alveolar destruction or septal thickening, okay, or any interstitial, barrier between the alveoli and the vascular bed, that will lead to a gas exchange deficiency.
Mm-hmm.
So it's very understandable that the DLCO is the diffusion capacity, the gas exchange capacity is affected in patients with emphysema, because the pathophysiology is alveolar destruction.
Mm-hmm.
Why, despite the being hypoxemic and hypercapnic, it's not affected in patients with chronic bronchitis, because the main pathophysiology is the mucus.
Hmm. Okay. One other thing that tend to learn a lot about is the very specific buzzwords to each of those subtypes. For bronchitis, what we typically hear is that it's caused by chronic irritation, typically by smoking, which is going to lead to goblet cell hyperplasia and then
Yes.
all of that mucus production. And in emphysema, there's a misbalance between all the inflammation and the anti-proteases, the ones protecting. So that's where we get like the alpha-1 antitrypsin. So is it possible to see clinically one type predominating over the other, or is it always sort of a mix?
Clinically, you mean?
Yes, clinically.
Yes, if we, for example, get the typical pink buffer or blue bloater, that tells you
Yeah, that's how. Obviously.
indirectly, obviously, that this is SEMA or chronic bronchitis.
Mhm.
If the predominant clinical presentation is the breathlessness and the tachypnea and not the cough, so we tend to favor emphysema over chronic bronchitis. If the predominant clinical presentation is chronic productive cough, then we tend to favor chronic bronchitis over emphysema.
Mhm.
Is that important, in terms of management? Not really.
Mhm.
Is that important in terms of prognosis? Again, not really. Because I mean, nowadays, it's it's rather academic. Of course, it's very important for you as medical students
Of
to
course.
differentiate. You need to learn science, perfect science, and then, practically things might slightly change. This is clinically, but I mean, is it difficult to differentiate between the two syndromes in terms of investigations, so radiologically or in terms of a specific test to phenotype these patients? No, it's very easy actually to differentiate between the two syndromes.
Mhm. Okay. So, yeah. So going off what you mentioned, the diagnosis, a lot of us, when we hear about COPD and we memorize the buzzwords FEV1 over FVC
Yes,
less than 70%,
yes.
many of us do not really understand the reasoning as to why that is. Why does the forced expiratory volume in the first second drop so much, so much more than the FVC?
Yeah, of course, because I mean, as we said, the main pathophysiology of the disease of the COPD is the early closure
Hmm.
of your airways during expiration. So,
Right.
due to either the chronic inflammation, the mucus overproduction, mucosal edema, the epithelial edema, or the alveolar destruction, patients with COPD tends to have an early closure of the small intermediate airways, mainly during expiration.
Hmm.
And that means they will require longer time to exhale in the entire inhaled or inspired volume. And that's why they will have a prolonged phase of expiration.
Hmm.
Okay. And the volume that they exhale within the first second tends to be much less than expected.
Right.
In normal individuals, for those who do not have any airway disease, we are supposed to exhale a minimum of 70% of what we inhale during the first second. Okay. And it takes us few more seconds to exhale the remaining 30% of the inhaled volume. And we do not keep any of the inhaled volume.
Right.
Of course, we do have residual volume,
Residual volume.
but that residual volume is fixed.
Hmm.
Okay. And there is also a functional residual volume. So at times when we are more tachypneic, like during exercise, when we exercise and we are more tachypneic, we tend to have slightly higher residual volume, but later, I mean, we compensate for this when we stop exercise, when we calm down. So that is dynamic.
Hmm.
Okay. But those patients, due to what we said, I mean, the alveolar damage, they have a increased residual volume,
Hmm.
which is persistent. It get worse during exercise. That's why those patients become more dyspneic during exercise.
Hmm.
And on the other hand, due to the early closure of their airways, they need more time to exhale, but they still do not exhale all the inhaled air.
Right.
Okay. And the fraction of exhaled volume during the first second is much less than the normal or than the expected for healthy individuals. And that's why their FEV1, the fraction of exhaled volume during the first second, is much less than 70%, or should be less than 70%, depending on the disease severity.
Right. Okay. So now for some of the chest X-ray findings. So some of what we learn are things like flattened diaphragms, for example, or
Yeah.
the barrel chest.
Yeah.
How much do you see that in your actual clinical
We
practice?
do. I mean, the typical radiology, basically, I mean, we said it's not very difficult to differentiate or to confirm the diagnosis of COPD. So, on top of the typical clinical representation, the chronic cough, chronic productive cough, breathlessness, the significant or relevant smoking history, and your clinical findings on examination, the chest X-ray tends to have there are typical features on chest X-ray in COPDs. Those patients should, or the typical radiological features of COPD is the hyperinflated chest, the flat diaphragm because of the increased residual volume or air trapping that will lead to pressure on the diaphragm. That pressure on the diaphragm leads to dyspnea, and radiologically, the diaphragm looks flat. The heart silhouette tends to be a smaller. We call it the tubular heart or the tubular heart silhouette. And of course, for those who have chronic bronchitis, you might appreciate on the chest X-ray increased bronchovascular markings.
Okay, perfect. Now, doctor, if you could just briefly tell us about the role of alpha-1 antitrypsin in emphysema pathogenesis.
Yes, actually, it's not one of the common subtypes of emphysema. Alpha-1 antitrypsin deficiency is a sort of inherited type of emphysema. It is as far as I can remember, it's an autosomal recessive gene when there is a lack of the alpha-1 antitrypsin. That leads to overactivation of the trypsin, which is a protease enzyme, and that will lead to destruction of the alveolar walls, leaving these patients with an emphysema at an early life. Of course, it has several subtypes depending on the gene deficiency and penetration. Whether the inheritance type is homozygous or heterozygous. But I mean, this is not our subject. What we need to know about the alpha-1 antitrypsin deficiency because of the activation or lack of suppression of the trypsin, those patients present with liver bronchial disease and early emphysema. The disease tends to be more severe in smokers. So lots of patients with alpha-1 antitrypsin deficiency, they have a very mild disease that does not require any type of treatment if they do not smoke, and the disease tends to be much more pronounced clinically if they do smoke, especially those who have the two allele deficiencies. In every emphysematous patient who presents at an early age, you have to think of the alpha-1 antitrypsin deficiency and send for the enzyme level. In terms of management, it depends on the disease severity. The first advice is, of course, it's the general advice for all COPDs is to stop smoking, because that can lead to less disease progression. And of course, we manage them in general the same way that we manage patients, COPDs. Of course, if they have liver disease, the treatment has to be combined between liver and pulmonary. Some or a small group of these patients who have a very severe disease, they might be candidate even for a lung transplant. In terms of enzyme replacement, is very complicated. It's not the routine way of managing these patients. It's just experimental, and it's not done as a routine practice. We just manage them as COPDs. Because, I mean, obviously, when we see them, the damage is already done, and it's permanent damage.
Wouldn't, like, hypothetically, if we were to do a lung transplant in a patient with alpha 1 antitrypsin deficiency, couldn't the same problem potentially reoccur because the enzyme deficiency is still there?
It does, but actually, this is a developmental damage. So
Mm.
the damage happens when these patients, where these lungs are developing.
Right.
Okay, so that's why you get this. You don't get it at a very early stage or at a very early age. So we don't see it in pediatrics or in children. We see it in adults, but young adults.
Right.
So the damage is actually developmental damage.
Right.
Now, when you transplant the lungs, they are mature, fully developed lungs. So the effect of the enzyme on the transplanted lung is very, very minimal.
Right. Okay. Makes sense. Plus, like immature lung developmentally, I'm sure would be predisposed to
Yes,
more severe damage
yes,
because of the enzyme deficiency.
absolutely. Yeah.
So when we talk about management of COPD, is there much of a difference between the management and the management for, say, asthma, or do we sort of try to focus on the same goals?
No, the management is different. Of course, yeah. One thing that maybe we have not mentioned very clearly that in the vast majority of COPD or chronic obstructive disease is a smoking related disease,
Mhm.
and the cause disease relationship is very strong with in smoking. COPD probably is one of the strongest cause disease relationship amongst all pulmonary medicine.
Mhm.
So it is a smoking, in the vast majority, is a smoking related disease. Of course, you will have the small group of patients who have environmental exposure or alpha 1 antitrypsin deficiency. And there is an entity called idiopathic COPD. So when you don't see any non-smokers, no exposure,
Right. No
no
risk
al-
factors.
no ris- no obvious risk factors,
Right.
but they still have clear emphysema on the CT scan and they behave like COPDs. So there is a small entity called the idiopathic COPD, but in the vast majority, in general, this is a smoking related disease.
Mhm.
And the damage is due to smoking. So it's a smoking related chronic inflammation of the airways or alveolar destruction. And you need a certain level of smoking or period of smoking to develop COPD. So in general, you need to smoke heavily.
Mhm.
20 pack years is normally the cutoff. And
Right.
that's why we hardly see COPD as below the age of 35.
Mhm.
Because if if the smoker is smoking with an average of 20 cigarettes a day, so one packet of cigarettes a day, they need 20 years of smoking with that average to develop COPD. So if it started at the age of 15, let's
Mhm.
say, because you hardly see, somebody who smokes with an average of one packet a day who is
Right.
younger than 15 years old. So you need the 20 years, so 35. So it's very rare before the age. We see it, but it's very rare before the age of 35 or
Right.
practically speaking 40 and above.
Right.
So it's smoking related disease, and the disease is seen in relatively older patients compared with asthma. The symptoms, despite they are similar: cough, sputum production, breathlessness, minus plus wheezing, but they tend to be persistent and progressive. It's not periodic. It's not urinal. There's no variation of the intensity. If anything, the disease tends to or the symptoms tend to progress with time. They will have the period of exacerbations when the severity of the disease gets worse. But even when they improve to the baseline. They don't go back to normal. So it is a persistent progressive disease. And in terms of lung function interpretation, it is a fixed airway limitation. So it is a fixed airway constriction.
Mhm.
Some of the CFDs might have limited reversibility, but definitely they do not reach the cutoff, which is the 12% and 200 ml of improvement to bronchodilators.
Right.
Otherwise, this will be asthma. Now, how we manage them, of course, because COPD is a smoking-related disease, so the first step is actually to stop the causative factor. it's not a trigger. It is the main cause, it is the causative factor. It is
Right.
the damage producer. So you have to stop smoking, and this is the only proven intervention that prevent the disease progression. And to some extent, it can have an effect on the mortality.
Mhm.
Because if you stop the disease progression, in another word, you might improve the life expectancy and reduce the mortality. In terms of other interventions that can make a difference, if these patients are hypoxic, so treating them with oxygen, some of these patients might require even long-term oxygen treatment. So providing oxygen can improve the mortality in these patients. The third intervention is what we call the lung volume reduction surgery,
Mhm.
or the lung volume reduction intervention, because that can be either surgical or bronchoscopic. So again, that can improve survival in these patients. So the only three interventions that can improve survival in these patients is smoking cessation, lung volume reduction in emphysematous patients who have heterogeneous emphysema, and oxygen supplement, plus, of course, preventing exacerbations, i.e., the routine immunization or vaccination for these patients. Otherwise, some medications that we offer to COPDs does not significantly affect the disease progression, rather than just improving the symptoms, intensity of the clinical presentation, and the quality of life. Of course, this is in general. There are some medications who can slightly improve the lung functions in these patients, but in terms of disease progression, none of the medical treatment actually, or the inhalers that we offer to COPDs, will significantly stop the disease progression.
Mhm. We did learn about a drug called roflumilast, which is a phosphodiesterase 4 inhibitor that
Yes.
could be used for severe COPD.
It's not routinely used,
Right.
because obviously its side effects can be added to the routine inhalers that we use, the bronchodilators that we use for patients with COPD. It is not actually routinely included in guidelines, in gold guidelines for COPD treatment. It is something that you can add for severe patients who have significant disease progression, and not candidates. They have disease progression despite treatment, and they are not candidate for lung transplant.
Mhm.
Yeah.
I think then it would be safe to say that COPD is sort of managed more on an outpatient treatment method rather than inpatient treatment.
Yes, I mean, it's like asthma,
Right.
because, I mean, again, most airway diseases, asthma or COPD, the management is actually outpatient management, unless patients have sort of flare-ups or exacerbations.
Right.
This is when they might require to be treated as an inpatient. So it is, because, I mean, both diseases are chronic diseases, and that means the mainstay of management is outpatient follow-up.
Mhm. Right. So then what would be the admission criteria, like very specific bullet points in order to know whether or not to admit a patient with COPD?
Of course, I mean, to admit these patients, they need to be acutely ill, and in general, they need a treatment or a specific direct attention as inpatients. This is the general rule. Otherwise, if whatever medical treatment or intervention to offer can be offered as an outpatient, it's always better to treat these patients as an outpatient. So during exacerbation, we tend to decide clinically and pathologically, to try to decide whether this is an infective or non-infective exacerbation, and then treat accordingly. But still, if the patients are hemodynamically stable, they are not acutely hypoxic and requires oxygen treatment, they are not in respiratory failure and required assisted ventilation, and their level of infection does not qualify them for parenteral antibiotic treatment, they can be treated as an outpatient. Criteria for admission: if these patients are acutely hypoxemic, you need to offer them oxygen. they don't have oxygen at home. They are not patients with chronic respiratory failure, and have facilities to have oxygen supply at home. So hypoxic patients with respiratory failure who might need assisted ventilation through a non-invasive ventilation or even mechanical ventilation, or those who require parenteral antibiotics. These are the main criteria for admitting these patients. Otherwise, even during exacerbations or flare-up, these patients can be treated as an outpatient. Of course, we're not talking about complications because, COPDs might present with a complication related to COPD, like, for example, having a pneumothorax in patients with emphysema. So secondary pneumothorax during or due to emphysema requires an admission because that might require also an invasive intervention.
All right. I think, again, for the section that our listeners are going to be tuned in to the most, what are some of the most common mistakes that you see during OSCE stations asking about COPD?
Yeah, well, for asthma and COPD in general, for the airway station in general, the most frequently encountered mistake is the difficulty differentiating between the two diseases. Because, as we said, by far these are the most commonly encountered airway diseases worldwide. The prevalence of these diseases is high worldwide, and of course in this part of the world. And clinically, patients present with very similar symptoms. Physical examination can be very, very similar. So you should have, the enough hints to be able to differentiate between the two diseases. And of course, the other mistake that it happens, or you can encounter in the OSCE, is mixing the management. It's similar, but it's not identical. So the way that we manage the asthma exacerbation is different from the way that we manage COPD exacerbation. The long-term follow-up for asthma is different from the long-term follow-up for COPD. General advices for asthmatic patients is different from the general advices for COPD, and let alone the disease or the disease prognosis.
Okay. What about the respiratory chest examination? What are some common mistakes that students can make during the examination?
Of course, when the session is about bedside chest examination, you need to be thorough, and you need to cover the four main parts of the chest examination, like any other physical examination. You cannot ignore a part. For example, do inspection, palpation, and ignore percussion. Of course, I always tell medical students that physical examination is not a written rule. Despite that, all references and examiners, tutors teach you to do it in this order: inspection, palpation, percussion, auscultation. But if you want to do it in a different order, or during the exam, if you miss a part, very simply you can come back and do it toward the end. So as long as you cover everything towards the end, is fine. So you don't need to panic if you have missed a part of the physical exam, and you don't need to show that, okay, actually you made a mistake by missing something.
Right.
The other thing is, very simply, it sounds silly, but however, this is essential, and it always has a mark on your OSCE that you need to examine standing on the right hand side of the patient. It's
Right.
very obvious, very simple. It sounds silly, but you can't imagine how many candidates stand on the left hand side of the patient. Here in our OSCE, we just tend to correct the examinee, and of course he will lose the mark for this part. But in international exams, if you stand, it's considered as a fatal mistake.
Wow.
In OSCEs, there are certain mistakes, they are called fatal mistakes. So if the examinee, does one of these mistakes, that means your exam is done. And sometimes the entire exam, not only the station, that station is done. So if you examine a patient standing on the left-hand side, very simply, in an international exam, they will stop you there and ask you to leave the room, and you've failed that station. So if you, for example, forget to ask the patient whether they have pain somewhere and try to avoid the area
Right.
of the pain, or even if they tell you that I've got a pain here, and you know, because you are anxious, you are not gentle, and the patient showed, you know, some agony due to the exam, that means your entire exam is done, so you will not be allowed to continue. Now, talking about our OSCE, one of the most encountered mistakes, for example, is not to do symmetrical exam. Because, you know, again, examinees forget that we have two lungs. So whenever you have two parts of the same organ, so your exam has to be symmetrical. So you have to compare. You cannot auscultate one lung and then move to other. You cannot percuss one lung and move to other, regardless whether you are collecting the right signs or not. If your exam is not symmetrical, you won't get the mark. Physical exam is all about having a system in your mind. So my general advice to all listeners, to all of you, you need to practice.
Right.
Nothing can replace practicing the physical exam. And if you, very simply, because I mean, I tell this to all medical students, if you just ask yourself, okay, as a physician, what will be what's your main job? And the answers that I get from medical students is to treat patients, to cure patients. Actually, this is not your job. Okay, our main job is not actually to treat patients.
Okay.
Ultimately, we treat patients. Ultimately, we might cure patients. How many diseases are curable? We just talked
Very
about two uncurable diseases. We cannot cure asthma. We cannot cure COPD. I can tell you now that 2/3 of my patients are uncurable. I'm a lung cancer physician. Lung cancer is uncurable in the vast majority of patients. Okay, so our job as physicians is not to cure patients, and not even to treat patients, because again, 50% of your patients will be treated by someone else.
right.
So your job actually is to diagnose your patient. Okay, and if you are good and at making the diagnosis, you are a good physician, because again, the vast majority of your patients will be treated by someone else once you make the diagnosis.
Mhm.
Now, if you ask yourself as a physician, how do I make a diagnosis? What is the best way? What is the best tool to make the diagnosis? Is actually to take good history
And to do a good physical.
and to do good physical examination.
Of
Okay,
course.
these are the two tools that cannot be replaced, and these are the main deciders between good and average physician.
Right.
Okay, so you need to know how to take good history from the
Mhm.
patient within the limited time that you have. Okay, so how to direct your patient towards the, you know, what you need to get from the history, and to do physical examination. Physical examination cannot be taught by reading a book. You can't comprehend a textbook about physical examination. You stand in front of the patient and you go blank.
Right.
And believe me, you know, no matter how good you are, the moment you stand in front of the real patient, you will go blank unless you've done this many times.
Mhm.
It's like driving a car. You
Yeah.
don't learn driving a car by reading a book.
Yeah.
Okay?
Of course.
You can be a good driver just when you practice well.
Mhm.
And nothing replaces, you know, good practice with physical exam. Your OSCE is only 8 minutes. Practically, it's 8 minutes. Okay, it's
Mhm.
10 minutes, but you know, you lose 2 minutes for the discussion.
Mhm.
So it's 8 minutes, and it's not easy to complete full chest or respiratory examination in 8 minutes unless you have done this many times before.
Right.
So you have to practice. It has somehow to turn into autonomic, unconscious.
Mhm.
As long as you think of what I have to do next, that means you are not good at your physical exam. It has to be completely autonomic, completely unconscious. You do it correctly without thinking.
Mhm. Yeah. Yeah, we had a session yesterday with a doctor from the hospital, and he was telling us how probably more than half of the patients who ultimately end up getting lab tests or any tests done could have been diagnosed with just a thorough history
Of
and
course,
physical
of course,
examination. Yeah,
of
so it's
course.
very important.
If if you want, or actually, in the future, a computer, I mean, even nowadays, with the vast advancement in AI and technology, patients can diagnose themselves,
Mhm.
okay? Or they can pretend that they can reach the diagnosis. But I mean, you just need to enter your symptoms, and your computer will tell you the differential diagnosis and direct you to what investigations you need to do. And then your role as a physician is completely skipped.
Mhm.
Okay.
Yeah.
But that can be very misleading. Okay. Very misleading.
Right.
So nothing replaces good physical examination. And I'm a strong believer that for maybe thousands years ahead, nothing would replace your stethoscope.
Thank you so much for the insight, doctor. If we can take another pivot from the obstructive diseases and move on to the restrictive diseases,
Okay.
could you tell us what do we mean by interstitial lung disease and how that's different from idiopathic pulmonary fibrosis?
Well, I mean, idiopathic pulmonary fibrosis is an interstitial lung disease.
Okay.
Okay.
Right.
So this is just a part. Maybe this is the main interstitial lung disease, but interstitial lung disease, or ILD, is a medical entity of the respiratory medicine.
Mhm.
Well, I mean, to understand what interstitial lung disease means in general, okay, yeah, you have to understand that the lungs, or you have to think of the lungs as three main parts.
Mhm.
Okay, if you think of the lungs means airway,
Right.
and then the interstitium that surrounds the airways.
Mhm.
Okay, that interstitium is the lung parenchyma and the vessels. Okay,
Right. Okay.
and then you have the
All right.
surrounding, which is the pleura and the chest wall.
Mm-hmm.
And any lung disease, whatever, I mean, if you read a textbook of medicine, I can guarantee that whatever disease that you read will come under one of these three entities.
Mm-hmm.
Either the disease will be an airway disease, or will be parenchymal disease, or will be like a pleura chest wall disease. There's no disease that can go beyond these three main syndromes, or three main entities. So we've talked about the main airway diseases, the asthma, COPD. Of course, there are some other airway diseases like bronchitis, bronchiolitis, and other airway diseases, but the most common is the asthma and COPD. Now, for the interstitium, or the lung parenchyma, so diseases of the lung parenchyma come under interstitial lung disease. So
Right.
interstitial lung disease is the big umbrella for any disease that affects the lung parenchyma.
Mhm.
Okay. Of course, those diseases tend to end up with fibrosis.
Mhm.
Fibrosis will lead to shrinking of the lungs.
Right.
And that's why these diseases are in general titled as restrictive
Right.
lung diseases.
Mm-hmm.
Okay.
Yeah. The way that I like to think about it is when I'm comparing the two is that with obstructive diseases, you sort of have a problem with exhalation. And when you have restrictive, you have a problem with inhalation. That's the way I like to think about it.
Well, I mean, if you want to be more specific,
Yeah.
okay, obstructive airway diseases, you have a problem with exhalation,
Mhm.
while restrictive lung diseases,
Mhm.
you have a problem with inhalation and exhalation.
Okay.
When you have the problem with your respiration in general, inhalation and exhalation, that is likely to be parenchymal and not airway.
Mhm.
While if the problem is in your airway, the main pathology will be in the exhalation, not the inhalation.
Mhm.
Okay,
Right.
because actually with interstitial lung disease, or what the common say the lung fibrosis,
Mhm.
okay, the problem is not in your airways. Your airways are intact,
Right.
but they are restricted by stiff parenchyma,
Mhm.
and that's why logically your inhalation and exhalation is affected.
Mhm.
Okay.
Right. Okay, so what is the main difference between the patient populations with obstructive lung diseases and restrictive lung diseases? So do we typically see interstitial lung diseases in more older patients or?
In general, yes.
Mhm.
Okay. Because the most common type of the interstitial lung disease is a very big umbrella.
Mhm.
And there are too many diseases that can come under interstitial lung disease, amongst them some rare diseases that can be seen in younger individuals. But what I learned when I was actually a junior pulmonary fellow, and I was rotating with an ILD, one of the ILD, figures in the UK. So in my first day, he told me, look, Mohammed, until you finish your rotation with me, there will be 5 diseases. I will not give you any excuse not to know, these inside out.
Mhm.
Other diseases, that's fine. They are rare. We will not see too many patients. You need maybe whenever you see a patient to read more. But the 5 diseases, they are very, very common, and you need to know them, by heart, which is the idiopathic pulmonary fibrosis, the
Right.
IPF,
Yeah.
the NSIP, the non-specific interstitial pneumonitis,
Mhm.
the organizing pneumonia,
Okay.
okay, the sarcoid,
Right.
okay,
Yeah.
and a drug-related interstitial lung disease.
Right.
So these are by far the most common subtypes of interstitial lung disease. Otherwise, other entities are very, very rare, or you don't see them quite frequently. And if you want to think of these diseases, most of these diseases are actually diseases of older patients compared with airway diseases.
Mhm.
Of course, asthma is, if we want to compare interstitial lung disease with airway diseases, asthma is a disease of the younger population,
Yes.
and COPD is a disease of older patients, but it's very obvious that it is a smoking-related disease.
Right.
Okay, so that makes the differentiation between the, let alone the clinical presentation. But if we say that, okay, patients is presenting with dyspnea, because asthma, COPD, ILD, all will present with dyspnea.
Mhm.
So how do I differentiate dyspneic patient, whether this is bronchial or airway? Younger patients, asthma, smoking-related COPD, and ILD has nothing to do with smoking, apart from some entities can be smoking-related, and you hardly see ILD in younger patients.
So, if it's okay with you, I'd like to just name a few of the most important subtypes of ILD, and if you could just give us a brief
Mhm.
high yield summary of each of the following. So, starting with idiopathic pulmonary fibrosis.
Yes, idiopathic pulmonary fibrosis is the main type of idiopathic pulmonary pneumonitis. As from the title of the disease, it is idiopathic. So it is sort of one of these diseases that so far we have just theories of the causative factor, but there's no proven link between cause and disease. It is a progressive disease that ends up with advanced respiratory failure. It is normally seen in middle age adults, from age of 50 onwards, slightly more common in a male compared with female patients,
Mhm.
and it leads to progressive pulmonary process. The disease is progressive. We don't have medications that can reverse the disease, so it's irreversible interstitial fibrosis. However, for the last maybe 10 years, we do have medications, mainly 2 main drugs or medications that can slow the disease progression.
Mhm.
And for those who have a advanced disease progression despite treatment, so the ultimate management or treatment will be the lung transplant.
Right. And those drugs would be the antifibrotic kind. So the
Yeah, these
nintedanib.
are the antifibrotic medications. The 2 medications that we do have so far is the nintedanib and the pirfenidone.
Pardon.
Both medications have been approved by all major medication control bodies, and they both are available for patients with proven idiopathic pulmonary fibrosis.
Mhm. Okay. And next, if we can discuss sarcoidosis. Now, this one is a little special because it's more of a multi-system
Yes.
entity, but it tends to target the lungs pretty, like in majority of cases. Is that true?
True, yes. True and not true. Actually, it is systemic disease.
Mhm.
Okay. So it is a disease that can affect the human body from head to toe.
Right.
So there is a skin sarcoid, there's a neurological sarcoid, there's ophthalmic sarcoid, there is a GI sarcoid,
Mhm.
there is a orthopedic sarcoid,
Cardiac.
and there's cardiac sarcoid, and there's pulmonary sarcoid.
Right.
For some reason, pulmonologist just stepped forward and decided to treat sarcoid.
Okay.
So we treat sarcoid even if the disease is affecting multiple systems, unless there's no lung involvement, which is
Right.
very rare,
Mhm.
because it tends to affect the lung plus other organs. Sometimes you might get pure neurological sarcoid or ophthalmic sarcoid without lung involvement, but this is very rare. So pulmonologists tend to treat most sarcoid patients, and if they do have other system involvement, so it can be like a shared care of these patients. It is a disease of unknown etiology.
Mhm.
Um, it is considered as interstitial lung disease, but actually sarcoid can affect the lung parenchyma, airways, and pleura.
Right.
So it's not purely the lung parenchyma which is affected. It tends to cause a chronic inflammation in the peribronchial areas, leading to restrictive, obstructive pattern on spirometry or peak flow. It is clinically a disease that can go in 4 stages. Of course, it affects relatively younger patients. The typical age is between 30 and 50. Females tend to be more affected compared with male. I think the ratio is 3-1. And it has some geographic distribution. So
Right.
sarcoid can be seen in certain areas more than other, and it is encountered in the West more than the East. So it's not an endemic disease in this part of the world.
Mhm.
And even in the West, I think it's more seen in a black population more than white, for
Mhm.
whatever reason.
Right.
So male, female, black is the typical patient with sarcoid. Clinically, it goes into 4 stages. I'm talking about the pulmonary sarcoid.
Yep.
So it starts with bilateral hilar lymphadenopathy, followed by some interstitial infiltrates. Then the lymphadenopathy tends to improve, but with further progression of the interstitial infiltrates, and ends up with end-stage fibrosis.
One quick, just as an aside, sort of to this whole conversation, there's this thing that we always hear about ground glass opacities seen in lung diseases and honeycomb lungs. Now, is that something specific to a subtype of ILD, or is it seen
Yes.
in any
Yes.
of them?
I mean, honeycomb is advanced fibrosis.
Right.
Because I mean, we talked about the general phenotype of the diseases. We did not talk about the pathological correlation of the diseases. So, because I mean, I'm sure that you've heard also about UIP and non-UIP. So when we, for example, talk about idiopathic pulmonary fibrosis, okay, so that's the clinical title of the disease.
Mhm.
But the pathological correlation, or the pathophysiology of, or the histopathology of the idiopathic pulmonary fibrosis is the UIP.
Right.
Okay. But if we want to take it from the reverse point of view, UIP, okay, is not the pathognomic idiopathic pulmonary fibrosis, because it is seen in any advanced fibrosis.
Mhm.
Okay. So, i.e., if you take a biopsy from a patient with idiopathic pulmonary fibrosis, you will see UIP. Okay.
Right.
However, UIP can be an advanced pathophysiology for other interstitial lung disease.
Mhm.
Honeycombing in general is a part of the UIP.
Okay.
Okay.
Right.
So the pathology of UIP is constructional damage of the parenchyma with interstitial fibrosis, honeycombing, and traction bronchiectasis without any evidence of inflammation. So that, i.e., there's no ground glass changes
Okay.
and there's no cystic changes. Okay.
Right. Okay.
That means the disease is end stage, is advanced. There's no inflammatory process, and that's why we do not treat IPF with anti-inflammatories. Okay,
Right.
we just treat them with antifibrotics to slow the disease progression. Whenever you use anti-inflammatory, that means there is a chance that you might be able to reverse the disease. IPF is irreversible. That's why anti-inflammatories have no role.
Okay. All right. Now, on the same topic, could you tell us a little bit about non-specific interstitial pneumonia, or NSIP?
Yeah, this is probably the second most common type of interstitial lung disease. It is not actually an entity per se, but
Right.
this is the interstitial lung disease presentation of too many other
Right.
entities.
Similar to UIP.
Yes,
Yeah.
yes. So it is a very, very non-specific presentation clinically, the histopathology, and it could be either idiopathic or secondary to other diseases like the connective tissue disorders. Okay. So there is a specific entity called CTD-ILD, or connective tissue disorder related interstitial lung disease. So with vasculitis or connective tissue disorders like SLE, rheumatoid arthritis, myositis, dermatomyositis, Jugan, all these diseases can have lung or respiratory presentation. So if the lung parenchyma is affected, because I mean these diseases can affect the lung parenchyma, airways, or even the pleura. But if the lung parenchyma is affected, so the typical ILD presentation will be NSIP. With NSIP, you get a mixture of inflammatory infiltrations, peribronchial infiltrations with lymphocytes. You get some parenchymal nodularity, ground glass, and septal thickening, but without clear honeycombing, unless this has progressed and developed into a UIP pattern. So the end stage of the NSIP will be the UIP when patients have end stage fibrosis.
Right. Okay. You also mentioned drug-induced
Yes.
ILD. Could you tell us which drugs specifically cause?
Well, in general, any drug can affect the lung. Okay. So there is actually groups of drugs that can affect the lung, and it's very difficult actually to list number of medications. Actually, you have to list a group of medications. So what you could say, okay, there are antibiotics that can lead to interstitial lung disease. There are antiarrhythmic medications that can lead to interstitial lung disease. There's anticonvulsive medications that can lead to ILD. There are immunomodulators that can lead to interstitial lung disease. There are checkpoint inhibitors that can lead to interstitial lung disease. There are immunotherapies that can lead to interstitial lung disease. So the list is massive. And in general, any medication can lead to interstitial lung disease. However, there are certain drugs which are very well known to lead to interstitial lung disease. Medications like amiodarone as antiarrhythmic medication, methotrexate. Despite that, we use methotrexate, for example, to treat sarcoid, but we are always vigilant that methotrexate can also cause interstitial lung disease. Some antibiotics like the nitrofurantoin can lead to interstitial pneumonitis, and the list is actually endless.
Okay, right. So I heard about bleomycin,
yes,
the anti-chemotherapy.
Yes,
drug.
you
Yeah.
you name it, but bleomycin is one of the most commonly encountered medication that can lead to interstitial lung disease. And to make it even more tricky, the lung toxicity of bleomycin get magnified with oxygen treatment. So
wow.
these patients, we start them in bleomycin, they start to have lung pneumonitis
Mhm.
and they become slightly hypoxic. You offer them oxygen, and then the toxicity of the bleomycin just gets worse.
Okay. Now, since it is the most commonly seen subtype of ILD, which is IPF, could you talk to us a little bit about the clinical manifestations of the disease?
Yeah, it is not dissimilar actually. We can talk about the clinical manifestation of ILD in general,
Okay, perfect.
because actually, of course, there are specific diseases that have different clinical
Right.
or some specific clinical manifestation. But if we want to talk about ILD in general, those patients present with dyspnea,
Mm.
or actually, to be more specific, progressive exertional dyspnea that might or might not be associated with a chronic dry cough.
Mhm.
The cough with interstitial lung disease tend to be dry because it is not an airway disease,
Right.
but airway irritation.
Right.
So that's why those patients, if they have cough, it is dry. The dyspnea, to start with, it can be mild, exertional, and then those patients will notice with time that their exercise tolerance is getting limited, or more and more limited, due to the dyspnea. So it is progressive exertional dyspnea. And there will be some other symptoms related to the primary disease if the interstitial lung disease is not an idiopathic type.
Mhm.
So if it is like a connective tissue disorder or vasculitis related, those patients will have the symptoms relevant or related to their primary disease,
Right. Of
whether
course.
it's rheumatoid or SLE or
Right.
other type of vasculitis. Now, of course, the drug-induced ILD, again, those patients will have the clinical presentation of the primary disease for which they are taking the medications, whether this is a hematologic disease or malignancy, or a heart disease, arrhythmias, whatever. Sarcoid, again, because it is a multisystemic disease, so there will be lung or pulmonary manifestations. This could be a dry eye or uveitis, symptoms
Right.
of uveitis. Quite frequently, those patients get arrhythmias, skin manifestations, like, the lupus perennial, erythematodes, or other skin manifestations.
Mm-hmm. Okay. Now, you very kindly clarified my point about restrictive lung disease as being a problem with both inhalation and exhalation, as opposed to obstructive, which are just exhalation. How would that reflect on the pulmonary function tests?
Yeah, I mean, the reflection is quite typical.
Right.
As we said, because the main pathophysiology is not in the airways, so it is in the lung parenchyma. So that restricts actually the lungs, affect the elasticity, the lungs become stiff, and airway becomes more restricted.
Mm-hmm.
And as we said, that affects the inhalation and the exhalation, the inspiration and expiration. And that's why both parameters, the FEV1 and forced vital capacity, both will be affected and reduced.
Mm-hmm.
So either they are reduced, with the same percentage, or the vital capacity will be slightly more affected than the FEV1.
Right.
And that is reflected on the ratio. So normal or high ratio, it favors restrictive lung disease, while low ratio favors obstructive lung disease.
Mm-hmm. And does that apply to all subtypes, or is there specific subtypes that acts a little bit differently?
There are, because we said that, for example, sarcoid is not pure parenchymal, so it might affect the
Right.
parenchyma and the airway.
Mm-hmm.
So people might have a mixed picture sometimes, or they might, even patients with sarcoid might have an obstructive pattern on the spirometry rather than a restrictive pattern.
Mm.
So it can behave slightly differently. There are also some interstitial lung disease that can have airways affected, leading to, on top of the interstitium or the interstitial lung disease, they might have bronchitis or bronchiolitis. So again, they might have a sort of a mixed pattern or an obstructive pattern, despite that this is by definition or classification an interstitial lung disease.
Right.
Normally, interstitial lung disease with fibrosis leads to a definite restrictive spirometry. Without fibrosis, then it can be mixed or less clear restrictive pattern.
Right. And that pattern, is it due to, I was solving a question the other day, and it was about the pulmonary function tests of an interstitial lung disease. And the answer was increased radial traction. And while I understand the pathophysiology generally of restrictive lung diseases, there was just this thing that I couldn't really understand, which is, what exactly does that mean, increased radial
Yeah,
traction?
because I mean, the airways,
Yeah.
the airways are not, we said that airways are not affected in general.
Right.
So it is the interstitium which becomes stiff.
Mhm.
When the interstitium is stiff, they just pull the airways. So
Okay.
that leads to what we call traction bronchitis.
Right.
So there's no limitation of the air coming in, okay, but there is a limitation in the elasticity. And that's why, because your airways are not that elastic, so they cannot expand to take more air in, okay, and they cannot really have the elastic recoil to blow the air out. So what comes in,
Right.
is blowed up. Now, because you have the restriction, so you are limited with the amount of air you get in, okay, but you can still force the air to go out within the first second. That's why both parameters are reduced, but maybe your vital capacity is more reduced than your FEV.
Okay. All right. And with that, I can safely say that we covered a lot of high-yield pulmonology topics today: asthma, COPD, and ILDs. But let's not forget the human side. Behind every concept we master becomes a moment of clarity, comfort, or relief for someone trusting us with their health. Thank you guys for listening and for caring enough to learn about this. We would also like to thank Dr. AlHajji for accepting our invitation. We truly, truly appreciate you being here with us, Doctor. And thank you behalf on all of the students listening and benefiting, for all of the times that they listen to this. This episode would not have been possible without your help and without your support. We wish you all the best. Until next time, stay curious and please keep learning.
Thank you. Thank you very much. I can say that I've really enjoyed this session today. It is a new experience to me. I haven't done this before. It's been enjoyable. I hope that I could have been helpful, and I'm more than happy actually to help, any medical student, he might need my help. Thank you very much. Been very enjoyable. All the best to all of you. Thank you.